Okay, hi. So, welcome to all our viewers and all our new and repeat viewers. Today, we have the pleasure of welcoming Dr. Raghavendra Pillappa from Virginia, who's a friend of mine and well known to the lung pathology community. He was, like Matt and myself, he was trained at Mayo Clinic for pulmonary pathology and now is a practicing pulmonary pathologist and also is interested in immunohistochemistry. And of course, as always, we have Matt Cecchini, who is moderating this session, as well as we are very, very delighted to welcome back Irene Sansano for this session to join our discussion. Actually, I think it's much more interesting when we have multiple people, contributing to the discussion. So welcome, Raghav, and take it away.
Thank you very much, Sanjay and Matt, for inviting me to this exciting discussion. It sounds more like a chit chat kind of discussion on YouTube. And also, thank you, Renee, for making time today. And hopefully, I can bring some fresh air as you, my cases are as fresh as your fresh air. I have a transbronchial cryobiopsy digitally
Nice.
scanned slide here. I do have a case history, but I just want to show the slide and then maybe I can give you the case history and then go from there. What do you guys think about that plan?
Sounds great.
Okay. Okay. So here's the transbronchial cryobiopsy. So again, there's a question of adequacy. As long as I see tissue and I'm able to make a diagnosis, I feel it's a sufficient biopsy. Again, what do you think, Sanjay and Matt, about adequacy in transbronchial cryobiopsies?
Matt?
I agree completely. If there's a diagnostic feature, then it's diagnostic. I think it gets a little bit more questionable when there's not, and how much do you need to see for it to be adequate? I think that is largely a context-specific question. I think it depends on what they're going after, and I personally don't have firm cutoffs that I need to see X number of alveolar spaces. I usually give them an estimate so they have a measure of their quality, but I don't have firm numbers of how many minimum that I need to see. I don't know what you think, Sanjay.
Irene, any thoughts?
No, the same. If you find the thing that it's diagnostic, it's enough. But to start talking about things like patterns or an NSIP or things like that, you need a big piece of well inflated.
And I would
parenchyma.
say that conversely, I don't know if you guys would, I think you would agree. I mean, conversely, let's say you have 7 big pieces of lung, right? You have lots and lots of lung, and there's nothing diagnostic there. It's non-diagnostic. You know? So you can have a really, really great biopsy, which is also non-diagnostic, which I think sometimes does happen with cryobiopsies. Is
Yeah.
you have just 7 pieces of normal lung tissue, or very minimal findings here and there. So, Raghav, what do you think?
Yeah, that's what I think too. If it's enough for making a diagnosis, then it's good. Otherwise, some people also mention zero point 0.5 centimeters. In some literature, they mention it. But like you mentioned, if we have only medium-sized blood vessel or just an airway without any alveolated lung parenchyma, or you cannot tell if there's a central sampling or a peripheral sampling or centrilobular or peripheral sampling, then what do you do with that? You just say that there's enough tissue, means there is adequate, it's not adequacy, there is tissue present but it's not enough for an optimal evaluation. So that's what I think. I agree with you guys.
By the way, just parenthetically, sometimes we have an ILD conference, multidisciplinary. It's the word multidisciplinary is in it, so it must be very important, right? It's ILD conference, and there's a biopsy which is only just exactly like you described, Raghav.
Yeah.
The artery and airway wall, right? There's no lung in it. Then it comes to multidisciplinary conference, and you're there sitting saying, "This is only artery and airway wall," and everybody looks at you like with a blank stare, as if you don't know what you're talking about.
But it's a half a centimeter. It's a half a centimeter, Sanjay. So it must be diagnostic.
It must be, and there are 7 pieces of airway and 3 pieces of artery. It must be diagnostic. What are you talking about?
Yeah.
Cannot you say anything on that?
Okay, sorry, Raghav.
Yeah, so we do have a big medium-sized blood vessel here, and then I do have some small airways here. You can also see small airways with accompanying blood vessels. So that can tell you that there is some central lobular kind of area sampled. And then we have much of the alveolated lung parenchyma here. I don't see any pleura or any soft tissue. Sometimes you can see that in the biopsy as well. So this is what we have.
Quite a lot of inflammation, isn't it? Interstitial
Yeah.
inflammation.
Yeah, a lot of blue dots.
Yeah.
Yeah, that's what I use when I'm describing to my residents. I see a lot of blue dots, a lot of looks like some lymphocytes in there. And it's mostly in the interstitium because the air spaces appears clean
Hmm.
in the most part, but there is some material here like a proteinaceous material. It could well be because of the procedure. But otherwise, the interstitium is maybe mildly thickened or enlarged because expanded because of this inflammatory cells. So, and then if we go down,
Mm.
you have some collagen type fibrosis, or do you want to call that ropey type collagen?
No.
No,
No.
there's some
Not
plasma
yet, Raghav.
cells.
Not yet.
Yeah, yeah.
Yeah.
So there's some histiocytes, otherwise there's lymphocytes, there's an eosinophil. We're very sensitive about eosinophil in the lung
Yeah.
because normally we don't see them. If we see them, we always mention it. Uh, so keep moving.
Mm.
There's some areas where there are histiocytes. There are lots of those histiocytes, but some areas I felt there was some histiocytes aggregating
Yeah.
into clusters. Let me take you to that area.
So all three of us already know what you're hinting at, Raghav, and
Hmm.
from
Over
that
there.
description, but
Yeah,
we would like to see it. Yeah.
yeah. Do you consider this
Yeah.
as a granuloma or polyform granuloma? Means not. I don't think it's yet there. Uh,
Um, it's a wannabe,
yeah,
not
yeah.
quite
It's
there yet.
right. It's trying to attempt. It's trying to attempt to become a granuloma, but not yet there. Again, you can see this elongated cells,
Yeah.
histiocytes, elongated cells.
I feel like some of these granulomas are only a granuloma that a pulmonary pathologist would call, right? If you showed this to anyone else, they would be like, "Oh, it's
Yes,
not a granuloma." But
Yeah.
these poorly
exactly.
formed granulomas, I think that we see, I think our
Well,
threshold is potentially lower.
if there's a bird, there's a granuloma. If there's no bird, it's not a granuloma. That's what happens in ILD conference, right?
Yeah.
It depends
Yeah.
on the number of birds the patient has.
Yeah, this person works in a departmental store, so I don't know if she has ever been exposed to a bird. Maybe if she's going to some zoo or something, we don't know, or maybe having a friend's bird. Sometimes people can have others' birds at their homes looking after them. Uh, Also, similar kind of inflammation was seen around the airways too.
Can
You
I
can,
interrupt 1 second here, Raghav? Do you
yeah,
have any bronchus here, or is it all bronchioles?
all bronchioles. I
All
don't have any,
bronchioles. Right?
yeah, I don't
Can
have
I
any
tell you, one of my
cartilage.
pet peeves in pulmonary pathology is when you show a biopsy that has only bronchioles and people say, "Do you see any bronchocentric inflammation?" And I
Mm.
tell them, "I don't even have a bronchus. How can I
Yeah,
see any bronchocentric anything?"
yeah,
They go, "Well, in HP, the fibrosis is bronchocentric." I go, "Okay, it might be, but there's no bronchus here. So
Hmm.
I can't say whether it's bronchocentric or not." People don't even try to make the distinction between a bronchiole, where, of course, we know is much smaller in diameter and much different than a larger airway process. So I think that distinction is worth making, something that is bronchiolocentric versus something that is bronchocentric. And of course, there can be conditions that are centered on both, both the airway, large and small airways. But I think it's worth making the point that what you have in this biopsy is all small airway, correct?
yes,
Relatively small airway. Yeah. Okay.
yes. So similar kind of inflammation is present around the small airway. Like you mentioned, there is no bronchus or bronchi. And again, all these places of inflammation, the histiocytes were present. They want to be like making a granuloma, but I did not see any even poorly formed granuloma, but there was an attempt for them to trying to make a granuloma, like especially like these kind of areas, and also several other areas.
Okay, can I stop you for a second, Raghav, and ask Matt and Irene now, without telling us anything else, Raghav? If you don't tell us anything else, is this biopsy diagnostic or non-diagnostic? What would you think?
I always make a diagnosis. Always, it's not a strong one, but with this I would call this pneumonitis with bronchiolitis, and these two histiocytes kissing in the dark. I wouldn't call it granuloma, but it makes me.
Did she really say two histiocytes kissing in the dark?
In the dark of lymphocytes.
That is perfect. That is like the
Oh my
perfect
God, I'm never
description.
going to forget that.
But they would make. I always say that to residents.
Yeah.
These two would make me look more deeply for granulomas. I mean, I would cut this biopsy one day and another day. I ask a cut and tomorrow I ask another cut for looking. If I cannot find a giant cell, convincing giant cell that I can sell to a resident, I would call it pneumonitis with bronchiolitis.
Right. So you would describe, right? So Irene, you're saying you would describe it, but you think the biopsy is diagnostic, correct?
Yes.
Matt, what do you think?
I would waffle a bit on it. I would probably be descriptive in my diagnosis and list a few differentials.
Is it diagnostic? Is the biopsy diagnostic?
Well, not for. I wouldn't outright call it chronic HP or HP. I think I would be a similar level.
But that's what she's saying too. So yeah. your only difference with her, Matt, is you're saying you're not sure it's diagnostic. That's the only difference.
Yeah. I guess in terms of what do you really call diagnostic, right? Like,
yeah, that's really why I'm breaking it up.
I wouldn't put it into a bin of a of a specific clinical entity. This could be if as Raghav was saying, if she had a bird, and this could be compatible with hypersensitivity pneumonitis. But
so let me ask you both this question again, Raghav. I'm not asking you because you know what this is. But the two of you, let's say you did see classic HP features, okay? Let's say you saw these beautiful giant cells, bronchiolitis, poorly formed granulomas, and occasional focus of organizing pneumonia, right? We all know we are talking about hypersensitivity here.
Yeah.
So if you saw the classic features, would you then call it in your top line diagnosis, would you call it hypersensitivity?
So I always correlate with the clinical pathologic features, and and if there's not a clear documented history, I make note that there's features consistent with, and in a comment, suggest further evaluation for potential exposures, because sometimes they're not clear, right? It sometimes is like they have a down-filled pillow or comforter, right? And the initial questions of do you have a bird aren't sufficient.
So that's exactly what I'm asking. I'm asking if you have an absolutely textbook classic case on a biopsy, but you don't know the clinical information, do you ever top line it as hypersensitivity pneumonitis? No? Irene, what do you do?
I would call it pneumonitis and bronchiolitis. I mean, I would keep my diagnosis, that is what I see. And then maybe if they told me the beautiful story with the parrot and everything, I would make a comment, maybe this is consistent with that. But, and if they don't have the story and I look and I find the giant cell in the interstitium, I would maybe make a comment saying, look for, check the history, or this could be, but I never give the diagnosis of chronic hypersensitivity.
Yeah, or not even chronic, just hypersensitivity pneumonitis.
Hypersensitivity, sorry.
So what you both are, if I understand you correctly, both of you are saying that you never give so it's never hypersensitivity pneumonitis in the top line diagnosis, no matter how classic the histology. But if you know the clinical setting, right, if they told you there's birds, there's mosaic attenuation, this and that, then you would top line it hypersensitivity?
No, for me in a comment saying this correlates with the history that they are telling me, but my diagnosis never changes. It's what I see.
What it is. What about Matt? Matt, what about you? So if you knew the clinical, let's say this patient has 30 birds, is a never smoker, has mosaic, has classic radiology, what would you say then in your?
I would write consistent with hypersensitivity pneumonitis, and then put, and all these I always put a comment. They're never just a one-liner, and
Yes.
and they will correlate with the clinical and the imaging.
That's very interesting. So so I'll just tell you what my practice is. So in the first situation, so if there weren't any granulomas, I would describe just like you, cellular chronic interstitial pneumonia, whatever. But in the second setting and a surgical lung biopsy, I do say consistent with chronic hypersensitivity, even if I don't know the clinical. And I know that I'm sticking my neck out a bit because sometimes it won't turn out to be clinically classic. But then my question is, if you have classic HP on pathology and not a classic clinical, what have you seen that looks exactly like HP on biopsy, but then clinically turns out to be what? So what is the alternative? So I'm asking both of you.
Toxicity for pembrolizumab or nivolumab. I saw something similar.
Looking like this, looking like a classic HP.
Looking like looking like an NSIP with giant cells in the interstitium. Maybe not bronchial-eccentric, but
yes, got it. Matt, what about you? Have you seen a classic HP on a biopsy that
turned out
turns out to be something else?
You know what? I think in those cases they hunt really hard, and I think you can find an antigen. But this is where I hesitate a little bit, because I think you can find an antigen in almost everyone, right? Like everyone's got a little bit of mold in their basement,
everyone
or
down pillow, and in
and this is what and this is what I struggle with, is that truly HP? And I don't know.
Yeah. Okay. So I think we have interrupted enough. Raghav, we'll give it back to you, because I just wanted to see what you do with the biopsy alone without knowing what the story is, because clearly there must be something more to this. Okay, Raghav.
No, I think the discussion was great. That's exactly what I do also. If the clinician hides the history of the patient, I hide my top line diagnosis as well and put it in the comment. And in the top line, I would just describe it like Irene was saying, cellular interstitial pneumonia or something like that with bronchiolitis. And I do mention the eosinophil, because that always a drug induced, you can keep it in the differential diagnosis. And then in this patient, we did have more history. The pulmonologist was telling me that the patient had a BAL with a predominant T lymphocytes. So that was another addition. And also the other
Not
things.
surprising, right, Raghav? I mean, that's not surprising, correct? I mean, this is a lymphocyte predominant inflammatory.
Exactly. So it correlates. And also this youngish woman, she works, like I mentioned, works as a departmental store, and they inspected her apartment and did not find any mold related issues or anything. But when they did our CT angiography, that's the imaging we got on this. Obviously, there was no embolism, but they noticed centrilobular nodules. And there was no expiratory images, because obviously they did a limited kind of imaging. So all I got was diffuse ground glass opacity, centrilobular nodules. Again, they did mention is diffusely present, but the biopsy was from a lower lobe. Again, I want to bring you the next question here. How important is the site of this biopsy? If they say it's a lower lobe biopsy, would you still do the same thing, or what would you do?
Matt and Irene first.
So I think the information of the site is important, but I'm always hesitant to make calls on distribution, because all these processes can be patchy. Yeah. And so I think in these smaller biopsies, really the CT is a better descriptor of the overall distribution of disease than what I have sampled in my small 0.5 centimeter piece of lung biopsy.
Irene?
Unless they say that there is another thing that I should have that I need to see. Yeah, I don't pay much attention here. You have many pieces of lung, and all do look the same. I think it's consistent with with all.
Exactly. I find this site thing to be very, very misleading, actually. Um, Matt actually touched on this on a previous episode where he was saying, he doesn't understand why DIP is a lower lobe predominant process. And, interestingly, people buy the idea that UIP is a lower lobe predominant process. But I would like to, just do a thought experiment. Just think of somebody gives you a biopsy and tells you this is a lower lobe biopsy, and you see classic UIP, right? You go UIP,
Mm.
perfect, peripheral, fibrosis, fibroblast foci, beautiful honeycombing, patchwork, everything you would want in any guideline or consensus. And they tell you lower lobe, you go okay UIP. Then they tell you, oh sorry, that's not a lower lobe, that's an upper lobe, and you go oh I don't know if this is UIP anymore.
Now it's
It's
NSIP.
just ridiculous. It's just ridiculous. This whole idea that UIP is lower lobe and cannot affect the upper lobe is so ridiculous that if you transpose it to something else, you would say this is completely ridiculous. If I told you this is squamous cell carcinoma and an upper lobe, you go, okay, great. Then I tell you, oh, sorry, it was a lower lobe. And you go, oh, now I don't know if this is squamous cell carcinoma. So I feel like we accept that so easily for ILDs,
Yeah.
but we
But
don't accept it for anything else. And in
y-
fact, like you both are saying, it wouldn't make any difference to you
yeah.
in this case, but
Yeah.
somehow for UIP, we use that site thing as a thing to take us to back or forth.
But if you were looking at the radiology and the radiologist told you that it was an upper lobe predominant fibrosis and the lower lobes were largely spared,
Yeah,
doesn't matter.
it doesn't matter to me if the histologic features are
No,
diagnostic.
no, I agree. It can have that, but I think that at least from the radiology world, that would make them. This is a case
Yes,
that should go to biopsy, right?
that's exactly what I'm saying, Matt. That's exactly what I'm saying is that when you change the site,
Yeah.
suddenly everybody is thrown. They're like, oh, it cannot be IPF because it's upper
Yeah.
lobe predominant. So let's find another name to squeeze it into. That's it. That's what I think is the problem. That's why we get pleuroparenchymal fibroelastosis, chronic HP, this and that, all kinds of nonsense, is because people don't accept that you can get UIP in the upper lobes too. I think this is
Yeah.
a big problem.
We
And
see
I'm
UIP
so
in
glad
ex
to hear from both of you that for this case, at least you wouldn't change your mind. It doesn't matter if it's upper lobe or lower lobe.
we see UIP in upper lobes in explants. I think it's a radiologic thing. You see the most of the thing in lower lobes, but I'm sure upper lobes have also fibroelastic foci and have the things that should have.
Yes. And so Raghav, what would it change your mind?
No,
Upper or lower lobe?
no. I try to like you mentioned. I try not to change my mind too much, uh, unless it is completely opposite than what I was thinking initially. But even if in this biopsy, if they say lower lobe, my diagnosis is still the same. It's not going to change. Obviously, the strength of confidence or that would change, because instead of a top line, I would mention in the comment so that keep it balanced and everything. But otherwise, it doesn't change for
Yeah,
me.
but if you're just giving a descriptive diagnosis, then there's not much to change, right? I mean, it's just a
Right?
description. It doesn't
Exactly.
change exactly. So you're saying I would go only this far and it wouldn't change if it's upper or lower lobe. But to be fair, you didn't really stick your neck out to begin with, right?
I'm not a brave pathologist.
Actually, the burden is on the person who sticks his neck out. So somebody, if
Yeah.
he says or she says that this is, cellular chronic interstitial pneumonia and bronchiolitis consistent with hypersensitivity, they're sticking their neck out, right? So they're saying, look, I think this is hypersensitivity regardless of the clinical situation or antigen. They're the one where the clinician will say, well, but this is all lower lobe predominant. There's no bird. How do you know this is hypersensitivity? Patient is taking nivolumab. So that's where you are making it. But if you're just describing, then it makes no difference where the biopsy is from, because your
that
your description remains the same.
that's why I like this comment
Yeah,
thing,
yeah,
because if you make the diagnosis with the information that they are giving, this information can change.
correct.
Imagine somebody understood parrot and was something else,
Yes,
and then they change it, and your diagnosis changes. It's
correct.
not
And
that
that's why I think this MDD thing has put a lot of stress on pathologists, because you cannot give a diagnosis because it will go to the MDD and change, depending on the clinical information. And I think this has been the major problem, is that people confuse the pathologic diagnosis with the clinical diagnosis.
Yeah.
And so pathologists, even if they see something that they would give a name to ordinarily, would say, well, I don't know, because something else will show up when we go to the MDD. And I think this is a big problem. I'm not saying there's an easy solution, but this is a problem because people don't want to stick their neck out even for histologically classic things.
Yeah. So in this case, like I had the information from the pulmonologist and a call and a little Zoom conference with the pulmonologist. So we were able to top line it as consistent with subacute hypersensitivity pneumonitis with all the supportive findings of BAL with increased lymphocytes, central lobular nodules on imaging, and also the HP panel later on found an environmental mold, something like Oreo basidium something. Uh,
Yes,
so
that happens, Raghav, in our setting. That happens in every,
yeah,
1 in 5 patients have some kind of environmental mold
right,
and a positive HP panel.
right,
So
right.
the HP panel is like this. If you believe the patient has HP, then the HP panel is beautiful. If you don't believe the patient has HP, well, the HP panel is frequently non-specific. So I think they do that a lot, especially in hypersensitivity, where it's such a fluid thing depending on the exposure and the other histories, that it's very easy to use tests in the way you want to when you know that each test is non-specific.
Yeah,
I
yeah.
don't know, Raghav, do you have any thoughts about your HP panel and how specific they are for HP?
Yeah, I don't have much experience with the HP panel because it's mostly the information which I get after I sign out, do the discussion and everything.
Right.
So I've not really gone into and see how many of my diagnoses were right after the HP panel with that information. If I would have done something differently, having that information even before the biopsy was done or during the reading of my biopsy. So I don't know about that information.
Yeah, I think this is reasonable. Matt and Irene, you have any thoughts about the fight, like what they sort of decided at the end of the day, HP in this case?
I think that fits. I think that's I think it's a good example of putting all the pieces together in a, with the input from the clinical side.
Yeah, it's basically my thought on that is this is a meh diagnosis based on a collection of meh findings. There's like yeah, could be on the biopsy, then there's a could be on the on the
Yeah.
hypersensitivity panel, and so there's like you put 3 or 4 diagnoses together and you get an HP. And I think I'm not saying that it's not HP. I'm saying that there's nothing particularly compelling about this case, right? It's like you do the best you can with the information you have. Correct?
But I think this highlights an important role of the pathologist, right, in bringing all these pieces of information together, so to give the patient an accurate diagnosis, right, and save this patient going from a surgical wedge biopsy, right?
True, but who knows if it's accurate or not, right, Matt? I mean, we are
Yeah.
the judges of. The best thing about the MDD is we are the judge and we are the jury, and we are also right. Once the MDD says that something is HP, who is going to challenge that, right? Because they are the judge and the jury of their own work. So
I get that.
yeah. Let's Irene, any thoughts about the HP diagnosis here?
If it fits, if it works, it's okay for me.
No, this is a great case to talk about this thing, Raghav, because this is something that we see a lot. I think, at least I'm sure you guys agree too. Just non-specific cellular interstitial lymphocytic process is quite common in lung biopsies, right? So it's very helpful to talk through this case.